Good afternoon, everyone. We are going to go ahead and get started. Welcome to this week's session. My name is Kate Tingley, and I am the Director of Marketing here at Infinix. We're excited to have everyone with us this week. Hopefully, you're dry wherever you are. I'm here in the Mid-Atlantic, and it's a rainy, dreary day here. So hopefully you're having sunshine and warm weather. This week's topic is how to explore missed revenue opportunities, a topic that I'm sure is something that keeps a lot of revenue cycle and finance leaders up at night. I'm excited to have Kero, our Chief Development Officer, here with us this week, and our expert on this subject. So Ron, let's go ahead and jump right in. Where do you see the biggest opportunity to uncover missed revenue?
Yeah, hey, thanks for the opportunity to be here, and thanks for the introduction. So Let me just start with a little bit of context. So in answering your question about where are the largest missed revenue opportunities, we have a wealth of information across many, many hospitals. I think we have clients in 19 states where we assess all of their revenue cycle opportunities from literally the point of patient registration through middle revenue cycle, all the way through to final collection or write-off. And in particular, I know part of the focus of this conversation is around specific challenges to rural providers. So I'd say the majority of our clients are rural hospitals and together with their own physician practices.
What are the biggest revenue cycle challenges for rural health providers?
Yeah, so this is something that we get to see firsthand every day. And I'd say probably the largest challenge is just simply the limitations of the talent pool in the community. Right? Many of these communities are very small. And if you need specialized knowledge, that person may or may not exist in your community with that knowledge. And it's often hard to recruit folks to move to rural communities. And so how do you get the expertise on your team that you need? So, many organizations hire and train, but then, your challenge is if you've got one leader of coding or one director of revenue cycle, if that person gets sick, if they leave, if they retire, where do you turn to for help? It is definitely a challenge, and COVID and early retirements have, I think, really exacerbated this problem for many communities where there isn't enough talent in their community to do everything they need to do from a revenue cycle perspective. And we're increasingly seeing organizations have to look outside their communities and get remote support because they can't get all of the help that they need locally. So I'd say remote support, whether it's for billing and AR follow-up, whether it's just to tap into other expertise that isn't available locally, whether it's a full-time on demand or part-time or part of some other relationship, I'd say is increasingly the trend. And, one of the, I guess, benefits of going through the COVID journey is it's demonstrated that business can be effectively managed remotely. And so it does unlock more potential and opportunity for many providers to have access to expertise and talent that they didn't before, when the business structuring was you had to be inside our four walls to be able to help us with those things. And so, right, it's a challenge, but now I think an opportunity. I would say the second challenge is just the tight budgets and the competition for resources in every hospital organization, right? If there's anything else that we see everywhere, is that we hear, almost everywhere we go, our team is too busy, right? We couldn't possibly take on more. We got a project list we want to get to. We don't have the resources to get to it. And I can't get budget approved more resources to cover more ground more quickly. because every other part of the organization is equally resource starved and working hard and equally looking for new resources. And oftentimes, unlike clinical departments, which often win those competitions, in the revenue cycle, it can be hard to make a business case because oftentimes, you have opportunity, but it's very hard to quantify. And so it's a budget request for perhaps a suspected but an unknown payoff. And so that is right. It's not an impossible scenario, but we see that as very challenging for many organizations that are struggling overall financially coming out of COVID. So I'd say that's a secondary thing. And I'd say third really ties back to the other two, which is in rural hospitals, it's hard to know what you don't know, right? It's a common scenario for us to go in and find, let's say, the director of revenue cycle services grew up in that community, graduated from high school, and her first job was doing AR follow-up for the hospital, and 15 years later is director of revenue cycle. That's a great resource to the hospital to have somebody who's been there that long, but it's hard for that person to know what they don't know, right? Who do they turn to? What kind of outside lens can you put on your performance to bring that national depth of experience to really look at, how are you performing in general across your revenue cycle, and what are your opportunities and what are the workflow opportunities, etc. I'd say the other piece of what you don't know is often around how do you leverage your electronic health record platform in the first place? Because oftentimes training was done long ago. It's costly to get new training. We've had staff turnover, and we hear time and again, we don't know how to get information we need out of the platform. There's things we'd love to do using technology, but we don't know how to do it. And so just, how do you get to a point where that you're leveraging the tools that you have available so that the people that you are able to get on your team are able to do focus on work that can't be done by the technology, so they can kind of run farther, faster, if you will, by letting the technology do what it was designed to do. But often we see that that's underutilized because the teams just don't know what the capabilities are, what the workflow opportunities are that you can build around that from a best practice standpoint. So I'd say, those are if I'm looking for what are the major themes for challenges in revenue cycle with kind of rural healthcare in general, I'd say those are the three big themes, Kate.
Right. So much truth in that. Why do you think charge capture optimization is such a universal challenge?
Yeah, Kate, I love that question. I'm going to read back to you here the results from our last 12 hospital assessments that we've done. This is a combination of hospitals, and as I mentioned, they're hospital-owned physician practices. This is just outpatient claims. The best performer that we've ever seen was in this sample of 12, was missing a reimbursable service on 6% of their outpatient claims.
Wow.
That's the best. Here's the rest of them. 12%, 12%, 14%, 16%, 17%, 17%, 22%, 37%, 42%. That's stunning, right?
Yeah.
It was stunning to the hospitals. There is not one hospital that we assessed that thought they had a charge capture problem. Not a single one. They all thought they were doing well.
It's so common though. I mean, you don't know what you don't know, right?
That's exactly right. That is exactly right. So that's kind of half of the coin, right? What percent of your claims are going out, and they're not right? But the other part is, how does that translate to how much cash can I put in the bank if I get them
Yes.
added to the claims.
Yeah.
And I would say on average, we see about 1% of net patient revenues. So that's a big number from a
Yeah.
single initiative, right? That means if it's $100 million health system or hospital, right, we
Mhm.
found $1 million net that they were missing. Now, our range has been from about 0.5% at the low end to
Mhm.
3% at the high end. And the bigger driver is the structure of the payer contracts. So because that varies a lot from organization to organization and from state to state. And the real question is if you add a reimbursable service under that specific payer, do you get any more money from it? And with some payer contracts you will, with other payer contracts you won't. And so of course you want to get them all right out the first time. And even if you don't get more reimbursement, you want that bill to include all the services that you actually provided. But I say that's the range. And so this is we have found this to be a hugely impactful need for organizations where they had no idea the leakage that they had from charge capture optimization. But I think that's a good stepping point to the second piece of this, which is the resourcing side that uses the output of the technology platform, right? We see organizations that have good technology platforms that are still missing charge capture opportunities right and left. And it's really for I'd say a result of two things. One, their people aren't experienced enough that are using the platform. So they don't know how to take the output and validate it in the medical records. And so they're missing things. I'd say that's part of it, but probably the larger problem is we haven't seen any hospitals where they have enough bandwidth on their revenue integrity team to chase down all of the potential identified claims that are missing a charge, right? Everybody's too busy. And, if you're pulled in 5 directions, it's rare that looking up another medical record where you might have missed a charge is as pressing as some other fire of the moment or the day. And so that work tends to get to the bottom of the queue and never gets gotten to. And right, nobody really knows on the team, well, what's the result of never getting to those to research them? Because there's no database that tracks those missed opportunities. And so it's really the marriage of the right technology platform with really experienced people that are really good at mining the technology, but you have enough of their bandwidth to actually get through the whole queue. Now that work demand, right? If you start from an assessment point of view where, you identify, let's say you have an organization, we found the 12%, they're actually one of the better ones. And we had 15 primary charge capture initiatives. That's a lot of work for that charge auditor to go back and review all of those out of the gate. 3 to 6 months later, when you fix 95% of it, it's not so much work. But you've got to get through that root cause fix phase so that you can afford the resources to follow up on all of the possible mischarges, right, with not so much volume to have to do every single day.
Right. I think you've proven what we've talked a lot about on office hours, which is, yes, there is such a huge need for technology and technology implementation, but that's got to be combined with the human intelligence piece. Technology is not the be all and end all. It's kind of that marriage between people and technology where we see the results.
Yeah. I mean, technology is the enabler to be able to do this. But you still have to resource it right. And I'd say over the last couple of years, right, the theme that I hear when I talk with organizations is my team is so busy. I'd like to tackle this and see what we're missing. How can I possibly fit it in I don't have the resources,
Right.
I don't have the bandwidth. Our IT team has even less bandwidth. How can we possibly do this? Right? Maybe we'll get back together in a year when I'm not so busy.
Right.
Right. I mean,
Right.
that's a lot of the thought process. And the way I respond to folks there is, number one, you're never going to have a time in the future where you're any less busy than you are today. This is the world you live in. It's our new reality,
Right.
and you're always going to be this busy.
Right.
So the question is, how are there paths where you can create more bandwidth? Because you don't have enough bandwidth, right? And there are certainly companies out there like ours, right, where we kind of serve as that new bandwidth to an organization. So just to, again, to kind of share what, some of the possible, we have a team of business intelligence experts that basically are replacements for the need to have any help from the hospital IT teams. So they know all of the EHR platforms inside and out, in fact, probably better than anyone on the hospital teams. And so if our folks just are able to get system access and system IDs, they can get out of that system all the information that we need to be able to do our work to help the hospital. So that kind of removes one big constraint, because nobody, right? I mean, I hear a lot about moratoriums, right? No more IT projects for a year. Well, this is a way around that bandwidth constraint. And for the team bandwidth, right, that we can, as I'm sure other companies can, structure our work so that we're completely new bandwidth to the organization. So your teams can keep focusing on what they're focusing on today, all of those current priorities. And our team is able to run with this charge capture optimization project kind of side by side with your team, not take up any more of their bandwidth, but really do all of the work from the data, from the root cause fix, even to update the claims and trigger rebills. I mean, when I say we can do it all, right? We've structured our company to be able to remotely do 100% of this. We have the auditors that can remotely review the medical records. And so it's a way to bring bandwidth to an organization. And then it's like, okay, but what about the budget constraints, right? How do I get my CFO to approve this? And right, I'd say, the only path that I've seen that's very viable to solving that is an at-risk relationship where, right, we work with our clients, we only get paid after they get the benefit. So there is no financial exposure to the organization. And so it literally is a free service until the benefit has been delivered. And then we get a percentage of that after the fact. And so you don't need a budget in that kind of structure because you're paying for our services or other company who has this type of structure with money you also didn't have in the budget. And so it's really a win all the way around from that standpoint.
Such a good point. Don't automatically mark something off your list because you assume you're not going to have budget for it, when the reality is there are cost structures and fee structures available that make it budget neutral for the client. So it's worth asking the question and having conversations.
Yeah, and I like to put this in terms of your own household, right? If there was something that you really needed, but you didn't have the money to pay for it, if somebody said, look, I'll go do all of the work, I'll get it paid for you, you can have it, and right, then you'll have enough money to pay me left over in your household, you'd say, this is wonderful. And that's kind of the way this structure can work for organizations. And so, we have talked to some where they know that they have a charge capture problem. They didn't think they could get to it. And this was a way to stop that leakage of money today, rather than waiting for 2 years when it finally can bubble up on your project list. And you think about, okay, 1% of net revenues times 2 years that you let go away that you didn't have to. And so I'm just, stressing this because there are more options out there available for organizations who think they can't fly any farther, any faster than they already are.
Such a good point.
So I'd say the last thing on my list is just, we certainly hear, especially in rural healthcare, how do we pick somebody? How do we trust that somebody is going to do a good job of helping us? And I would say, from that standpoint, I think it's a valid concern. There is no question that there have been many companies out there in the revenue cycle space that chasing money became a higher priority to them than best serving their clients, right? So there are some of those companies out there, but I would say the majority of companies like ours, our hearts are in the right place, right? We're in this sure to make money, but we're also in this because we have a passion about helping providers and rural healthcare be successful. And so if you do a good job with your networking and reference checking, you should be able to sift through who's going to be a good fit. Because what I would like to really emphasize, don't let lack of trust keep you from moving forward. And my analogy is, right, if you had a bad meal in a restaurant 10 years ago, that didn't cause you to stop eating. So,
Good analogy.
Yeah. So, Kate, I think that's most of, kind of the thoughts that I had prepared for this conversation. I don't know if you have any more questions, or if anyone who is listening in, I hope I've connected with, what some of you wanted to hear, found this interesting. But if you have any other questions, please, I'm happy to address them.
I don't think I've got any. I think the other questions I had, I think you actually answered already, which was great.
Okay. Well, if there are no more questions here, I hope that you all found this, a valuable, or at least a nice learning opportunity around charge capture. Maybe this just reinforced some of the challenges that you're having, so you realize you're not alone out there, that some of these things are kind of universal challenges. And for sure, if anyone has any questions, after this, I'm sure Kate can provide information. I'm happy to respond to anybody individually.
Yes, absolutely. As always, if you've got questions, you all have my email address. Don't hesitate to reach out. And I can certainly forward those on to Ron and get those answered for you. Always here to help in any way we can.
Super. Well, again, thank you. It's been my pleasure, and
great having you.
Have a great afternoon.
Absolutely. Thanks so much, Ron. This was great. And
okay.
Forward to seeing everybody here next week. Have a good one.
All right. Bye-bye.